I'm Danielle Cooper with the Department of OBGYN, obviously. I want to go ahead and get started with Grand Rounds so I don't go over too much. Here to talk to you about HPV vaccine. I have no disclosures unless somebody wants to pay me, then I'd happily disclose it. So we have some scholarly objectives to get through, as well as a bit of an agenda to this talk. And my agenda is we have got to get better at doing this. And so just hoping you guys will help me be on the front lines of getting this vaccine into our patients. And how can we do that? And today we're going to communicate some of the burdens of HPV disease in men and women. So how bad of a problem is this really? We'll talk about how good the vaccine is. Talk about ways as far as when should we be vaccinating and who, some ways that we can talk to our patients about getting the vaccine, and then where can we do this as far as our missed opportunities to be giving this vaccine and hopefully thinking about it a little bit more. So, very brief review. Isn't it pretty? At least you can just Google HPV. I mean, it's kind of pretty. But this guy's bad. He's bad news. He's a DNA virus. It's the most common sexually transmitted disease there is. There's over 150 types of HPV, 40 of them associated with genital tract infections, 13 oncogenic that we worry about. They cause, so the majority of people who are exposed to HPV are asymptomatic and will clear it. And it takes somewhere between 6 months and 2 years for them to clear it, but 90% of the patients who get exposed are going to clear this problem and may not even know that they were ever exposed to it. Those that develop persistent infections not cleared by our immune system can go on and develop these types of cancer. Cervical cancer is probably the most recognized and prominent one, especially in women. In men, it's oropharyngeal cancer, and this is certainly on the rise. Oropharyngeal cancer is also a problem in females, but just not as high. But it's the whole genital tract, vulvar, anal, vaginal, and penile cancers. So, welcome, come on in. How do I get it? Pretty much any type of intimate sexual contact. It does not have to be intercourse. And so just genital contact, touching, this can, the virus can be transmitted. And there was a survey, it was a little bit disturbing. It was, the CDC did in 2011. They surveyed high schoolers, 9th grade to 12th grade. It was called the Youth Risk Behavior Surveillance. And they looked at a bunch of different things: smoking, texting, alcohol use, sexual activity, those kind of things. 47% of the high schoolers had ever engaged in sexual activity. So between all 9th graders to seniors, half of them had engaged in sexual activity. 33%, or a third of them, were currently sexually active, meaning they'd had sex within the last 30 days. And then I kind of looked at some of the other things that seemed high. Half of these same individuals, half of these high schoolers had ever tried a cigarette, so tried smoking, but only 18% were current smokers. So the message is out, don't smoke, and they're stopping, they try it and they put it down. But they try sex, they like it, they keep having sex, okay? They're not stopping. Texting, which I would have thought would be a bigger problem, only a third of them were actually texting. So still more sexually active than doing some of these other risky behaviors. You dramatically increase your risk of getting HPV with multiple partners. So the seniors, 24% of the seniors or 12th graders have reported 4 or more partners. And this is a national survey. So, I'm not, it's not, well, that's just that high school. No, it's every high school. And my 6-year-old and 8-year-old are going to have trouble going to school because their mother's going to follow them everywhere. So it's a pretty big problem. And the burden of disease is fairly substantial. 79 million people infected with HPV. 14 million new infections a year. And half of those are in these younger age groups, 15 to 24. So this problem is a problem, and it's not going away. So 13 types that I mentioned that are oncogenic as human carcinogens. The real bad boys, 16 and 18. 16 probably being even the worst of all of them. But does anybody know what percentage of cervical cancer 16 and 18 are responsible for? Shout it out. 70%. Good. 70% of cervical cancer, 16 and 18 are responsible for. It's 66.5 or something, but it's not just cancer that's a problem. Okay, so 6 and 11. What does 6 and 11 cause? Genital warts. Good. 90% of genital warts are caused by 6 and 11. But over 350,000 cases a year of this is a problem. You know, it's not only something that can be annoying, it can be bothersome, painful, cause bleeding. Stenosis can obstruct the rectal canal or the vaginal canal, but you know, it's not necessarily going to cause cancer in them, but it's going to cause some problems, and it's very expensive as well. And it's affecting 350,000 people in the US alone every year. So 16 and 11 I mentioned were the real bad boys, and considered that high-risk HPV. But it's not just 16 and 11, and we'll talk about some of the 13 other oncogenic types that they're looking at. But the prevalence of high risk and low risk, especially in our younger age group, is going up. And so obviously, you know, my 14 to 24-year-olds are getting exposed potentially to 16 and 18. Over 70% of cervical cancer is associated with those, and they're my exposure group. Okay, I messed up that slide, sorry. So HPV-associated cancers and when you get them. Cervical cancer is what I'm pretty much going to be mostly talking about, but it's not the only one. But cervical cancer is a cancer of young women. The median age is 48. And we've got 12,000 new cervical cancer diagnoses a year, 4,000 women dying from it. It's number 7 in the mortality for cancer deaths among women. Now, it's not to be put off by the fact that a little bit older, average age 60 for anal cancer, oropharyngeal cancer 61, vulvar cancer 66, and 69 vaginal cancer. But again, it's a cancer of younger women. 25% are actually between the ages of 35 and 44. Another 15% between 20 and 34. You know, it's 1 in a million that are going to get cervical cancer under the age of 21, which is why we don't start screening yet until 21. But we have that 1 in a million in our clinic across the street. I've seen her. I hate seeing her. It just reminds me of how terrible this disease is. And again, it's a disease of young women. So again, cervical cancer is not the only HPV-related cancer. You can break it up between male cancers and female cancers. Oropharyngeal cancer is more common in males than it is in females, and about 70% of oropharyngeal cancer is related to HPV. And about 90% of cervical cancer is related to HPV. So we got to consider the rest of the genital tract as well. And even though I spent most of my life concentrating on just half the population, we don't want to forget about the other half. So where are the problems? If you just kind of look, I mean, the dark part of the country is the southeast. I don't know why Arkansas is hiding their data, but cervical cancer is a problem. You know, I don't know. This is all from the CDC website. You know, 8 to 9 per 100,000. One of the slides I don't have up here, we see this in minorities. It's a higher percentage of cervical cancer in minorities, especially African American and Hispanic. You know, it's our patients that we're seeing. Now the vaccine itself, there are vaccines. There's 3 of them. Okay. The vaccine is made from the L1 capsid protein, which apparently is the antigenic part. didn't really remember all my immunology, and so I had to reread some of this stuff when I was putting this talk together. But remember, it's a DNA virus, and there's no DNA in that vaccine. It's just this capsid protein that makes a virus-like particle, and your body actually mounts a bigger immune response to this than it does to the naturally occurring infection. So they can produce this vaccine in large quantities. You can't get the infection from the vaccine. You sort of, sometimes that's one of those myths that rolls around with patients. Well, I'm going to get that infection. My mother got polio from a polio vaccine, so I do know that it is possible, but not from this one, okay? It doesn't have the DNA in there. And it takes the DNA getting into your cells, those changing cells, to cause the dysplasia to lead to the cancer. But again, I can get a better immune response from my immune system with this virus-like particle. And they make it in yeast. So if your patient has a yeast allergy, they can't, some sort of allergic reaction to yeast, they can't get this vaccine. But if you think about it, it's kind of brewed like beer. They're made in these giant vats with yeast, which kind of makes beer drinking a little disgusting, but anyway. So the two most popular vaccines that have been out the longest is the bivalent and the quadrivalent. The bivalent is known as Cervarix more commonly, quadrivalent commonly known as Gardasil. Bivalent, again, it's got two of the HPV forms, 16 and 18. Again, responsible for 70% of cervical cancer. And then the quadrivalent added in 6 and 11, responsible for 90% of those genital warts. It's a 3-dose series in both of them. Target age 11 to 12 in girls and boys. And you can get, again, you're getting significant coverage because of the fact that 16 and 18 are responsible for 70% of cervical cancer. And we're seeing that, in fact, in the unvaccinated population versus the vaccinated population, they are mounting response to these. The 3-dose series, you give it 0 months, 2 months, and 6 months. And I'll kind of talk about this a little bit later. They're toying with an idea of a 2-dose series, and when I spoke with Dr. Bocchini, he actually sits on the advisory committee for immunization practices specifically for HPV. He said maybe this December or early January there may be some new recs about that, but for now, and especially the age group we're going to be intervening with, it's going to stay at a 3-dose series. So the newer vaccine is a 9-valent vaccine. It's called Gardasil 9. This is stocked in our clinics. We do have it. It was FDA approved in December of 2014. The 5 extra valents, 31, 33, 45, 52, and 58. By adding these 5 strains, there's an additional 15 to 20% point protection preventing cervical cancer. That brings us up to almost 90% protection of preventing cervical cancer. And I mean, that's amazing. All of the vaccines, again, that's the 3-dose series. Target age still girls and boys 11 to 12. Does anybody here know why they target girls and boys age 11 to 12? Why is that the recommendation? Before sexual activity, and there's another reason. Say it again. It's the best immune response. Your body actually builds a better immune response, and that has to do a little bit with the 3-dose series, and we'll kind of mention that in a few minutes. So in most developed countries like Canada, UK, and Australia, they have mandatory school vaccination programs, and the HPV vaccination rates are as high as 80%. That's completing all 3 doses, not just single vaccine. And they've seen a significant reduction, and I have a few slides about the reduction in CIN2 and 3, as well as genital warts associated with their vaccine programs. In the US, based on pretty recent data, so 2013, 2014, why those are flipped, I have no idea. In the adolescents, 13 to 17 years old, we've gotten better. So first dose for females, it was 56%, now it's up to 60, so we're a little bit better, but this is pretty pathetic when you look at Tdap and Menactra totals, 80%, almost 90%, 80% here. We can do better. And certainly when you look down, second dose, third dose, and then males, first dose, second dose, third dose, we're not doing so great. And we can get better. We're about 50% in Louisiana. We're better in Mississippi. Woo! That's it. But again, the Southeast being a problem with vaccines, and this is just a single dose, not even completing the series, single dose, we're about at 50%. Here's our Louisiana rates specifically. But if you look at Louisiana for Menactra, meningococcal vaccine, 91%, Tdap, 93%. We're good at giving vaccines. We're not just giving this one, okay? Males, it's worse, down to 40%. So we're not thinking about it. And we're way better than Arkansas, at giving vaccines, but they're beating us with HPV. So we can get better at this. So here at LSU, I had them pull what data I can get, and this is actually from the pharmacy, and this was from between January 1st to June 30th. This is just where they were stocking the Diebold. So it's not actually vaccines given. It's not even accounting for multi-doses that are given to, they give 3 doses to the same child. It's just where they're putting the vaccines. Peds is doing pretty good, and they should be. The indication is for 11, 12-year-old males and females. But catch-up is to age 26. So we should definitely be more involved. Medicine Clinic is beating us. I think they had like 60 vials stocked. Viral disease was a little bit lower at about 55. Women's Clinic had 30. Family Medicine had 25. So we're not giving it. We're not using it. And we can get better. Here is a breakdown of the ages that are getting it, again, between January and June of this year, as far as looking at who's getting vaccinated. Our 11 to 12-year-olds getting 1, 2, 3. Now we get a little excited, I'm giving some 4th and 5th doses here, so need to look in links and see if they've already been vaccinated. As far as we know, we haven't caused a significant problem, but definitely not necessary to get that many doses. But pretty big drop off in where I feel like we should be making a difference. 19 to 24, pretty low, okay? And so that's why I got these numbers pulled. So the vaccine works. Millions of HPV, like over 60 million HPV doses have been given at this point in the last 9 years and proven very safe and effective. And there are estimates from the CDC that if we could actually increase our vaccination rate up to 80%, like Australia and UK, that there would be an additional 53,000 cases of cervical cancer prevented during the lifetime of those that are younger than age 12. And I certainly won't put Dr. Roy out of business. He will still have plenty of it coming in, but that would be a significant change for sure. Since the vaccine was first recommended in 2006, 56% reduction in HPV infections among teen girls in the US, even with our lower rates of vaccination. So even though we're, hovering around 50% with single dose, about 30% for all 3 doses on board, we're still making a difference here. The 9-valent vaccine has shown similar efficacy. It offers about 97% protection against 31, 33, 45, 52, and 58. And then it was in a non-inferior immunogenicity study with the HPV, with the original Gardasil, and again, showing that it was basically it was equally as effective. Okay, so we need to be using the vaccine. Again, I mentioned Australia has this mandatory vaccine program, accomplishing an 80% vaccination rate. Their high-grade cervical lesions, so CIN 2 to 3, has decreased by 38% in women in this cohort that they have looked at. And then for vaccine-eligible females, in that proportion of genital warts has gone down 93%. And then it's also decreased by 82% in males, and they're actually attributing some of that to just herd immunity because, again, the vaccine for males wasn't recommended, I think it was 2009 or 10, when it started to be eligible for male. And the original cohort that they started in didn't include males, but they were seeing some effects of the herd immunity present. So it works, but is it safe? There's some interesting websites out there that you can look up. And University of Michigan has this one. It's called Risk Bites. I couldn't make it pull up into my program because I'm kind of illiterate when it comes to digital stuff. But it's interesting, and like I said, you just have to Google it, and it's a pretty short little clip on safety of vaccines and the information that's out there, because when you Google Gardasil vaccine, HPV vaccine, and go on YouTube, there's these horror stories that are out there. And, they made it to Good Morning America and the Today Show and stuff, but the fact of the matter is CDC is using at least 3 major ways to look at these vaccines. They have been tested and tested and tested. VAERS is the Vaccine Administration or Vaccine Adverse Event Reporting System, and this is sort of passive surveillance. It's case-based. So as clinicians or providers, you actually put the adverse events into the system, and this is open to any vaccine that you've ever been given. If you have an adverse event, you're to report it into this system, and they try to make it really simple. You can do it online, or there's a paper-based reporting system. I didn't even know this existed. I've certainly never reported to it, but I don't routinely give vaccines, so I just casually asked my pediatrician husband, and sure enough, yep, very aware of this system that's out there. And they do utilize it. It's a passive surveillance system. They routinely collect this data. They look for signals within the data, but it's sort of like it literally is individual cases, and it can be anything from a headache to I passed out, I can't walk anymore, I died from the vaccine, all that kind of stuff, literally. And then there's the Vaccine Safety Data Link. So they have all 3 of these ways. The Vaccine Safety Data Link is a more active surveillance group, and it's a large network of health maintenance organizations. And the best one I can always think of is Kaiser, because a lot of studies are done out of Kaiser's data. It's a closed system, but they have multiple networks of these data all over the country. And these guys have agreed with the CDC to monitor vaccines and get data about the vaccines and disease outcomes. So they can actually do retrospective cohort studies on the population, not just an individual report. And so they sort of complement that VAERS system. And they routinely do these cohort studies. Every time the media pops up with something, they go in and they'll do these cohort studies to look and see if there is a real problem with the vaccine or not. And thus far, they've seen no significant correlations, and we'll kind of get into some of that data. The other sort of the Clinical Immunization Safety Assessment Network, I couldn't find a whole lot on that one. It is with the CDC, but it's like the CDC structured with it, plus 7 medical research centers that are routinely, again, looking through this data, and other partners to provide safety and a public health service to the nation. And I wasn't as familiar, or couldn't find as much on them, but certainly VAERS and the Vaccine Safety Data Link. Sorry, I don't know why that clicked off. So there's, again, the ongoing safety monitoring, and what they've seen is the majority of issues are sort of non-serious and felt to be small issues. Site reactions, local injection kind of reactions where they're getting the vaccine, but they have a really low threshold for what they consider serious and non-serious. Serious is a headache. Serious is nausea, vomiting, or fevers. And so they're not just skimming off the top of the data and saying, everything's fine. Syncope does seem to be an issue. Now, the problem is they don't know if this is an issue because you're giving a shot or a vaccine to an anxious 11 or 12-year-old. But there does seem to be a link here. A lot of pediatricians are now currently recommending that most of these teenagers are probably a little bit dehydrated, and then anxious on top of that of getting a vaccine. And so the recommendation is to be sure they're hydrated and watch them for about 15 to 20 minutes after you vaccinate them to prevent something like a syncopal episode. Vaccine, so the safety data link allows for rapid cycle analysis to continue. Initially, when Gardasil first came out and there was a whole bunch of issues with it, they were looking at over 600,000 doses of HPV that had been given, and looked at vaccinated versus unvaccinated to see if there was any kind of association between some of these things, especially like Guillain-Barré syndrome and seizures, and saw no significant risk. And so they have a pretty good cohort. Now there's been over 50 million of these vaccines given and still no significant link. There continues to be ongoing safety with the CDC into the VAERS system, and encouraging clinicians of, if you give vaccines and you have a problem, you need to be reporting into this system. That's how they get their data. And then they're looking at it in specific populations as well, continuing to run these cohort studies, and especially in males. If you happen to give in, now Gardasil and Cervarix had registries that if you got it and you were actually pregnant, they were monitoring these, saw no adverse outcomes at all. They've actually closed those registries but opened a new registry for Gardasil 9. So still available to report in. And currently, when you go to give the vaccine, you don't have to run a pregnancy test on them. Now, you probably want to run a pregnancy test on them because if they're coming to our clinic, there's a good chance they're pregnant, and they just need to know that. But as far as giving the vaccine, you don't have to run a pregnancy test on them because there doesn't seem to be any problems with it during pregnancy, but not recommended to give it if you know they're pregnant. And they, as these cases come out in the media and concern arise, then they will run these cohort studies with the VSD vaccine safety data link. So again, the 9-valent vaccine, pretty well tolerated. Again, the safety data is kind of coming out of your earlobes. Side effects very similar, but there seems to be more of a site response to the injection, which makes sense. It's got 5 more valence to it as far as 5 more of those virus-like particles, so a little bit wider response on the skin, but that's it. Venous thromboembolism, so there was monitoring systems within the CDC and even outside the CDC, and they've combined all that data, and because there was risk of, or reports of risk of venous thromboembolism associated with Gardasil vaccine. And there are no risks of that, in fact, as well as the neurological conditions, autoimmune conditions. And again, we still see those site reactions and potentially syncope, so again, recommending that you watch that patient for about 15 minutes after you inject them. There's something I was going to say about the neurological condition, but I've lost my train of thought. So some myths out there, despite all the safety monitoring. These will still persist as long as there is YouTube, Facebook, and I can tell my story. We're going to potentially blame it on some of these things. But it's still a new vaccine. Now that Gardasil 9's out, it's an even newer vaccine. Just hit the box December 2014. So I don't want to give it to my child until it's proven safe. And hopefully you as a clinician have convinced you. There's been millions of doses of HPV given. They've got multiple monitoring systems, no connections with these vaccines, and serious side effects. This is a safe, effective vaccine. Myth number 2, my child is not having sex, so they don't need the vaccine right now. Now, quoting them a study about the high schoolers who are sexually active, not a good idea, okay? Not the right approach. But the fact of the matter is, I need to give this vaccine before they're having sex. So they're not having sex right now? Perfect. Let's give them the shot. They're not having sex, right? Now, your patient may or may not think that's funny. But you can also talk to them about the fact that you get better immune response at age 11 and 12. Also, which I hadn't really put 2 and 2 together until I was doing this prepping for this talk. So Tdap and meningococcus or Menactra are given at age 11 to 12. Their booster is given then. Why? Why do we give Menactra? What are we preventing? Meningitis. Do most 11 and 12-year-olds get meningitis? Who's at risk for meningitis? The college student that's living in the dorm kissing somebody, right? Well, I mean, I'm not telling that mom I'm trying to prevent meningitis in their college student who's going to be kissing on people. They're 12 years old. I'm giving them Menactra because this is when we give the injection, because this is the best immune response I'm going to get to this vaccine. Okay, so you have to kind of take the same approach, and we'll talk about that a little bit as well, with the vaccine. So 2 things to think about. They're not having sex, great. Ideal time to give it to them. They're not sexually active. Number 2, I'm going to get the best immune response out of this vaccine from the child. If I vaccinate my child against HPV, apparently it's permission to start having sex. No, it's not. And actually, the study that I listed here, let's see, I think it was published in Pediatrics, yeah. You know, that they looked at these kids that were vaccinated versus unvaccinated, and they are not becoming more sexually active in the vaccinated group versus unvaccinated group. And they were looking at things like follow-up visits for sexually transmitted infections as well, because there's, I'm not sure if it's on the next page, another myth that, you know, if they're going to be more likely, no, it's not there, but more likely to get other STDs if they get the HPV vaccine, and the fact is it's not true at all. It's not associated with higher risk of other sexually transmitted infections. So myth number 4, I can't receive this vaccine because I have a cold or a chronic illness, so I come into the clinic with a stuffy nose, and you absolutely can. Mild infections, now if they've, you know, moderate to severe infections, bad fever, puking their guts out in your clinic, you may want to wait till the next visit. They're just not feeling great. Chronic illness certainly need to be vaccinated. A lot of people say, well, if they're HIV positive, immune suppressed, you shouldn't give them the vaccine. Yes, you should. They just may not have a very good immune response to it. But you absolutely need to vaccinate them because they have a terrible immune system. They can't fight it, okay? But unfortunately, because they have a terrible immune system, it may not mount a very significant response. And of course, myth number 5, boys don't need the vaccine. Why are we giving boys the vaccine? I mean, because of herd immunity, I don't want you to give it to the girlfriend. Why are we giving it to boys? Right, so the studies that looked at it, I have to prevent something in the males, not just herd immunity for the females, but it was associated with anal cancer in males and decreased risk of anal cancer. We've now seen certainly decreased risk of the HPV-associated oropharyngeal cancers, so it is in fact recommended in our male cohorts. So why aren't we giving it? And the biggest reason is I'm at fault. Parents aren't choosing to vaccinate their kids. We're not telling patients to get vaccine, and it's because it's the recommendation is not coming from the physician. And if it's gaps in knowledge, if it's gaps in opportunity, it's kind of unclear, but the fact of the matter is less than 50% of parents who report that their children's clinician didn't recommend the HPV vaccine, so that's why they didn't get it. It's not that they are saying I don't want it. They're not even being given the opportunity to get it. And so the other thing is, you know, some people feel like, well, you know, I'm seeing all the complicated stuff, and maybe you have a PA or a nurse practitioner seeing just all your routine things, and you leave it to them to go over all the vaccinations. Well, you got to be sure HPV's in there, okay? And it really is our job to be talking about this. But studies have shown clearly that the provider recommendation is the most influential factor in that patient's decision to receive a vaccine. More parents vaccinated their teenagers, almost 70% reported getting because they got the recommendation for the vaccine from the clinician, compared to the parents of the unvaccinated teens. In 2013, 64% of parents received recommendation for their girls, but only 34% for their boys. So, you know, again, we have to kind of vamp up who we're talking to. Now, I'm not going to jump on you about talking to the males because I'm not going to see them either. But It's just got to become part of our dialogue with these patients. And we should be recommending it 100% of the time. You're still going to have people refuse it. You're still going to have people who refuse to vaccinate their kids, period, much less themselves. But if we're not telling them to do it, they're not going to do it. And then there's these missed vaccination opportunities. And, we don't have a whole lot of patients, especially not in the OBGYN clinic, that are coming in for vaccines only. In peds, that's fairly common. They've got their well kid visits, things like that, but certainly not in OBGYN. And so where can we find some of these opportunities and take better advantage of it? How do we talk about the HPV vaccine or frame the conversation in a healthier way so we're not getting into an argument with our patient and still convince them to vaccinate? And studies have actually looked at, this was an interesting one, that looked at the parents and what their estimate of the value of the vaccine is and what the clinician estimated the value that the parents put on the vaccine. And we obviously don't think that they think very much of HPV or flu, which is a little bit scary. And actually, the parents put the same value on that vaccine as all the others. And so again, we're getting in our own way here, and we need to get out of the way. So when we talk about patients and talk to them about HPV vaccine, conversation usually steers toward a dialogue about sexual activity. And we need to change that to one of cancer prevention. And because the real goal and the real focus, the point of this HPV vaccine is to prevent cancer. The JAMA article that looked at the incidence of sexually transmitted infection after HPV vaccination among the adolescents of vaccinated versus unvaccinated, and there was no evidence that HPV vaccine led to higher rates of STDs. So I can talk to this patient about reducing their own risk of HPV-related cancers or their child's. So, most of our patients have a son or a daughter or grandchildren, and that's one of the opportunities where we need to be making a difference as well. But we can reduce, their risk up to 90% of getting an HPV-related cancer with Gardasil 9. That's huge. 79 million people in the U.S. with HPV, with 14 million new infections a year. That's pretty significant. 12,000 cases of cervical cancer and 4,000 deaths. We need to be able to drop those numbers even lower when I have a vaccine that can prevent it. So the CDC has actually made some recommendations on how to talk to people, how we can get better at this, bundling your recommendations. So if they come in for Tdap, meningococcus, HPV needs to be added on. Answer all the patient's questions or parents' questions, no matter what they are, and try to get to the root. If they're refusing, try to get to the root of why. It may be one of those myths. It may be, they're worried that their child's going to become sexually active all of a sudden. Again, you kind of need to get to the why, and maybe it's just, I don't want to vaccinate, period, or I don't vaccinate myself. And okay, you don't necessarily have to badger them about it, but the more questions we ask to get to the bottom of it, sometimes the better the patient knowledge and the more acceptance that they become with the vaccines. Same way, same day. So you recommend Gardasil 9 the same way you recommend Tdap. So they're coming in, and with our clinic, I think it's going to be more with the flu as well, because Tdap we tend to be giving during pregnancy, but they've come in for their annual exam, everything looks great, it's time for your flu shot, Gardasil's on the way, the nurse will be right in. And you don't make a big deal out of it, you don't treat it any differently than you treat any other vaccine that you would give, or the patient will detect that and notice it and say, oh, I don't know that I want that one. Okay, now, again, we struggle to talk them into flu, but we're still talking to them. We're not talking to them. So we need to be talking to them about Gardasil 9 as well. Where I feel like we as OB-GYNs can make the biggest difference, and is RB in here? She's not in here. So I'm getting one of the interns to do a QI project. We can vaccinate them postpartum. They're here in the hospital. We give MMRs, we give Rogam, we give Tdap before they walk out of the hospital. We're probably trying to put something in their arm or in their uterus to prevent pregnancy. It is not a contraindication to lactation, but we need to be giving them the Gardasil shot. Yes, they're already sexually active, but we don't know what they've been exposed to, what they haven't. If they're under the age of 26, we need to catch them up, okay? And we have a great opportunity to hit them then, and then at their 6-week visit. Not quite that 2-month interval, but close enough. And if they actually come in for that 6-week visit. But we can at least get 2 of those doses on board and then get them back for that 6-month visit to try to get the 3rd dose and get them caught up. Any kind of contraceptive encounter, sexually active or not, again, I'm not going to see the 11 or 12-year-old. It's going to be rare. There are parents that bring them in and want me to talk to their kids. Happy to do it, but that's not where I can make a difference every day. I'm going to have plenty of birth control encounters. And so with the birth control, whatever option they're taking, if they have not been vaccinated with Gardasil 9, they need to start their vaccines that day as well. And so bundling your recommendations, okay? Certainly, if we're treating them for a sexually transmitted infection, they are obviously having sex. Let's get them HPV and Gardasil. Again, get them there caught up. Annual visit, anybody under the age of 26. That's part of y'all's H&P. I look at it every 6 months. Immunizations up to date. Are they really? Okay. Did you ask about Gardasil 9? And then recommend to your parents to vaccinate their kids, parents and or grandparents that you're seeing for their annual visit. And then making that vaccine or that recommendation personally. So if they ask me, or I will just tell them, both my 8-year-old son and 6-year-old daughter will get the vaccine when they turn 11, because I don't want them to get cancer. Not because I think they're just going to go out and have sex, because they're both going to get, there's going to be issues with their pants, but can't think about that. But I don't want them to get cancer, okay? And I have a way to prevent cancer. And so why wouldn't I take advantage of that? I don't want them to get measles, mumps, or rubella. I don't want them to get meningococcus, and I take them to places like Kenya where they can actually get that stuff. And so I vaccinate them to prevent it. So I need to vaccinate them to prevent them. And a personal recommendation goes a long way. Now, it will also help too. Sometimes it's convincing a culture. And I was trying to get around the clinic and invite as many nurses, and none of them took me up on it in here because, our nurses are sometimes our frontline faces. And if they don't believe in it, they aren't going to recommend it. Oh, you're getting that Gardasil 9? Okay, it's going to hurt. Hold on. Versus, oh, you getting your Gardasil vaccine? Okay, great. I'll be right back. We have trouble getting them to vaccinate or believe in the flu. We all know that getting the flu can kill some of our patients, right? But certainly getting the vaccine, am I going to give you the flu? No. But sometimes, again, you have to convince a culture. But we have to believe in it, and we have to educate them. And like I said, I invited them all, and they didn't come. But told them free lunch, but they still didn't buy it, I guess. But convincing your office that you're working in, if you believe in vaccines, I believe very strongly in vaccines, then when it's coming from you, it will come from them. We have a nurse-driven protocol for flu now. I think pneumococcus, I know in the hospital they do. And so encouraging Gardasil just to get added on. And again, that postpartum visit needs to be, we need to take more advantage of that postpartum time that we have them for 24 hours in the hospital before they walk out of here. So these are some questions that may or may not come up that hopefully you can answer now. I've already gotten Gardasil. I've gotten all 3 doses. Do I need to get Gardasil 9 now? And the answer is no. If you've already been vaccinated, again, you're protected up to 70% of HPV-related cancers, and it's not currently recommended by the CDC to get a dose of Gardasil 9. So I did double check that with Dr. Bocchini, and he said no, you don't need the extra boost. So if you've already completed it, you've completed it. If you're in the middle of the vaccine series, well, I've gotten 2 of the doses, but I need the 3rd one. You can give them the Gardasil 9. You don't have to restart your vaccination series. So you just complete it out, but you can give them the Gardasil 9 at that point. And I'm not positive, but I think they were going to pull all the Gardasil 4 valents from our clinic, and it's just Gardasil 9 that's there. If you want to give Gardasil 4, you can give it. They still have it, but what they were stocking in the Diebold was going to be Gardasil 9. Do I have to get all 3 shots? And what happens if I miss a dose? It is currently recommended that you complete the series, but this may be changing, like I mentioned before. But it's probably going to change in the other younger age groups. So the highest amount of serological conversion actually happens between the initial dose and the 6-month dose. Not a whole lot of conversion occurring at the first dose and the 2-month dose. But the WHO, the World Health Organization, has a recommendation for females, and it's just for females, it doesn't have it for males, under the age of 13, that they can go to a 2-dose series. Now, the current Advisory Council for Immunization Practices here in the US still says 3 doses. And so they have not gone to a 2-dose, but the WHO has, and it's 0 and 6 months to complete the vaccine series if they're under the age of 13. Again, it's not really going to affect our patient population because we don't see the same immunogenicity response that you will have in the child or in the young adult. So we certainly continue to recommend the 3-dose series. And if you miss a dose, you don't restart them on the timeline, just finish them out. Okay, so if they've gotten 1 shot and it was a year ago, give them another one now in 6 months or 4 months from that point, hit them again. Okay, so you just kind of complete them wherever they ended up. So does HPV cause infertility? I found this one on the internet. I was like, what? If you take out someone's uterus because of recurrent cervical dysplasia, now they're infertile. If I do a tricholectomy because of severe dysplasia, potentially they're infertile, or at least they've got an incompetent cervix and we can't keep that baby in there. So I'm not directly causing infertility, but remember it's a disease of young women. 40% of the women are in childbearing years that are getting cervical cancer. So not directly, but as you can see, it can certainly lead to and create problems that can cause infertility. So I told you at the beginning, we should be able to describe and communicate the burden of HPV disease in men and women. Mario, can you do that? Okay, well, tell me.
It's very prevalent with sexually active men and women. It is, the most common types are, HPV causes almost 100% of cervical cancer, and it's very preventative. The vaccines cover, the new Gardasil 9 can cover up to 90% of oncogenic types that cause cervical cancer.
79 million HPV infections, 14 million new a year. Okay, great. Efficacy of the HPV vaccine for preventing, you actually kind of covered that too, good job. You just got Priya out of it. When should the HPV vaccine should be given and recommendations? So one of my students, when should we give it? 11 to 12. What's the catch-up ages? Till 26 in males and females. Very good. Compelling information about HPV vaccine to parents and individuals. Kylie, can you talk to a mom now?
Yes.
Okay, give me an example. What would you say?
I would say that it would be important. I wouldn't even mention the sex thing. I would just say it's important to prevent cancer and tell them about cervical cancer being in young women.
Good. What about you, Bud? She took your answer. The other thing I would, recommending that they vaccinate themselves too, and your personal recommendation to vaccine if you have children or have been vaccinated yourself. Missed opportunities. Lauren, what's a missed opportunity?
Postpartum.
Postpartum, absolutely. Ashley, when's another missed opportunity?
They come in for STD screen.
STD screen. Give me one. Priya. She's like, who?
Just like when they're coming in for contraception, annual exams.
Fantastic. Needs to be on the tip of your tongue every time. Okay, good. That's That's all I got. I got lots of references. Any questions?
Is there anything that you show anything like vertical transmission?
So they're looking between mom and baby. You mean with papillomatosis? There's no definitive evidence yet, but in theory, yes, we should be preventing this if we prevent genital warts, which is associated with papillomatosis, which can be a big problem in those newborns, but no definitive evidence yet.
Any contraindication given Gardasil in immunocompromised patients?
No, only if they have a yeast allergy, then because it's brewed, well, it's made in yeast, and then if they're pregnant was the only other contraindication I saw.
That was what.
Okay, yeah. Yes.
In the over 26,
What do we do?
is it just insurance to pay for it?
Yes.
When they catabolic?
So one thing I forgot to mention, I'm sorry, I didn't talk about cost. So Gardasil 9, there's only about a $10 to $15 increase in the cost. Gardasil 4, or the sort of original Gardasil, was about $120, $130 average per shot. And Gardasil 9 is about $140. There are patient assistance programs. It is covered by Medicaid. You do not have to have it pre-sorted. I called several of the Medicaids, and they're like, no. I was like, okay, I'll believe when I see it. But then you do not have to have that pre-certified. But if you have a patient coming in requesting it, asking about it, would I give it? Absolutely. Could it be the equivalent of saline? Yeah, possibly. She's been sexually active for multiple years, then maybe I'm giving her a nice big dose of saline in her arm because she's had all those exposures. Odds of having all those exposures pretty low, right? I mean, likely she might have had 1 or 2, but all 9, probably not. And so you're potentially protecting her from something, but it's just not clear what. And again, you have to warn her about the cost because her insurance company is likely not to cover it.
That's one of the reasons we actually give it in our older patients that have recurring cervical vaginal vulvar dysplasia or venereal warts, especially in people that are immunocompromised by
Right.
medications and have recurrences after recurrences. Because there's actually data showing that you have resolution of these, that they're actually investigating as treatment for cancer as well as for dysplasias.
I literally saw something on SGO's website this morning about a potential vaccine that may be providing some treatment to some of these HPVs. I was like, oh, you knew that to me today? But I don't know enough about it, and it's not published data yet, but the SGO, they are working on stuff like this. So
Again, just because you have 6 or 11, you got venereal warts doesn't mean necessarily you've already
Right.
acquired 16, 18, 31, 33, 45, 55, etc. So it's still
Well,
be
and it's-
beneficial in those patients.
you know, you've had an exposure. Remember, your natural immune response is not as significant as those that are actually being given the vaccine. You cleared it, great, but what if you got re-exposed? You know, it's those that because you decided to pick up smoking, you know, because smokers don't clear it, right? Or some other really bad habit, I don't know. But you have a potential, 90% of them are going to clear it and not have any symptoms. But if you vaccinate them, again, there's no way, I'm not going to test them for what they've had before in the past or screen them or anything, but would I give it? Absolutely, I would. But you do have to warn them of the cost. And we're working on a program with pharmacy right now where they actually won't have to come back and have another physician visit. If you order the 3-dose series, you just put the order in and they actually just show up to the pharmacy and get their vaccine and walk out. Well, they have to be watched for 15 minutes and then they walk out. They might pass out. Any other questions? Y'all, please start vaccinating. We're going to look at these numbers again because, like I said, we got a QI project, and this is kind of sad. Medicine clinic was ahead of us. You know, I mean, come on. Now, I expect pediatrics to be way up there, right? And to stay way up there because that's where the original, you know, the obvious, getting to those young kids before they're sexually active, great. And Dr. Bocchini, I think, does a lecture like twice a year to the peds department. But we can do a lot better, okay? And we need to, for our patients, we need to. Okay, that's all I got. Thanks.